everybody, great to be here with you on World Eating Disorder Day, and thank you for the PCAC for having me and their webinar. My name is Annette, I'm from Berlin, Germany, and as well as having had an anorexia approximately 10 years ago, I'm also a patient representative on the German Treatment Guideline Commission. As such, because I didn't just want to speak to my own experience, but also broadly represent a more generalized experience of all eating disorders, I also did a small qualitative survey. One reason why I did this survey was just to give patients a chance to give feedback on aspects that maybe they felt like weren't seen enough in therapy, but also, more generally speaking, I was interested whether there were some factors amongst all people with eating disorders that can be classified as very helpful or very detrimental to treatment success. So, along these principles, the title of my talk today is Control is Good, but Trust is Better, Improving Treatment Efficacy Through Participation. And control in this regard stands for very rigid and I guess also very necessary protocols for on this more CBT type behavior area, and trust includes everything that is beneath the disorder and things like insecurities, difficulties, challenges, feelings, and tries to add them into the treatment as well. So before we start, a little bit more background on me. 10 years ago today, I made the decision to go into inpatient treatment after having had anorexia for approximately 3 years. I knew all this time that I was compensating some communicative struggles at home with my anorexia, and I had tried to communicate this, but it's just with people being different and also very stressed in situations where there's a lot of pain, it was hard to find a common ground in all the stress. When I came into treatment, however, or in the inpatient program, I had a therapist who was both able to tell me very clearly that I'd probably have to eat regardless of all the very painful struggles, but who was also able to hold a big space for me to feel these experiences and work through them and have them coexist at the same time. And crucially, I think it was neither nor, but it was always both, and upon me to make a good judgment which would be the most appropriate in any type of situation. And that sort of decision-making and principles also helped me long after I'd been in inpatient treatment and faced other challenges along the way of a very long recovery. And even if it was hard to find very specific help for them, I could always resort back to them. So that's why I was wondering whether they were just about me or whether they could be found in other people's recovery stories too, and if one could categorize them, if there was something to be learned to improve the treatment for all of us. So today in my talk, first of all, with these principles in mind, I'm going to talk about how somebody develops an eating disorder, what then becomes necessary in treatment for them to overcome it in a lasting way. Then I'm going to show you some of the results of my survey that I think illustrate my ideas to some extent. And lastly, I'm going to make some suggestions how to improve the treatment structure from a patient's point of view. So let's start. How does somebody develop an eating disorder? I think first of all, it's important to remember that it's in the name as well, it's called a disorder, it's not just an illness. So next to some biological markers that predict for it, there are also a lot of psychological components that make somebody develop a behavioral dysfunction. I guess, looking at it psychologically, it's called a compensation strategy, so that also reversely requires there to be some conditions that make the patient feel like it is even necessary to compensate these conditions or feelings in a way that is as extreme as an eating disorder. Adding to the challenge is the fact that oftentimes it's not one specific condition, but rather a complex mix of a lot of factors on various different levels, both in the environment and people's personality, in their relationship with people close to them, maybe in some ways that they see themselves. So it's a lot of aspects on a lot of levels. And I guess before we go any further into how that develops into eating disorders, I think it's important to remember that just having all this like trouble come together is always going to be a very challenging point in life for the person that experiences it. So, but with all of that, how does somebody develop an eating disorder out of that? So we start with yourself, and there's a lot of things that you do and that you enjoy and that give you balance in life. They're symbolized by these ovals here. And normally living a good and happy life means that there's an individual balance of all of them, and maybe you'll have an issue with one, but then the others will pull you through that. But if there starts to be problems in several of them, all of a sudden it becomes hard to maintain the balance and sense of self that you had of yourself. For instance, when you're a teenager and you're very focused on how you interact in society and come across anyways, you might experience problems at school with bullying or through pressure through social media, but also at home your parents might be getting a divorce and be very caught up in their own struggles, and then very easily it becomes hard to feel as secure in yourself as you would be. Also, we all lived through the COVID pandemic 2 years ago, and that was a huge external stressor as well. That would make it more difficult. So when these persist for a very long time, I think you want to hold on to the person you were, and obviously you don't want to like appear weak and you don't want to show to everybody that you're struggling, but also you don't really have the resources. So in the need, food, a basic necessity initially, comes in and sort of as a compensatory mechanism to give you momentary relief and clarity, and you start to develop eating disordered behavior. I think it's so salient and such a potent compensatory mechanism for people because of different reasons. First of all, you have something else to focus on. It occupies your mind. It also has a lot of structure to it and things you can obsess about. The self-control becomes synonymous with self-control in social situations. But then the question would be, well, you have all this now, why don't you come back? I mean, this could be a good resource, or like this could be a good stabilizing resource. Why can't you just turn it around? I think there's two things that work against that. First of all, I think it's only with having the relief of not struggling with yourself all the time that you even notice when you breathe out or like find shelter and safety, how much you are actually hurting. And as soon as you've had that relief, it's hard to come back. Also, this behavior gives you a type of identity for better or for worse, and it's hard to give that up again when you've been struggling to have one that is okay for you for so long. So I think first of all, these types of behavior are just where your attention goes, like where you direct a lot of your energy. So we have the orange bar here, and it takes up a significant amount of your attention, but it's not all of your attention or your personality. But the more you do it, the more your attention goes there, the less other parts of your identity get less of it and fall away. And also it becomes habitual more and more. And of course, the more that happens, the more really the other parts of your personality become less and less accessible because you just use them less and less. Doesn't mean they're not there anymore. They're just buried under a huge load of focus for your eating disorder. And then, after even more time and no change in these type of dynamics, the personality becomes so weakened and the habituation of the eating disorder so strong that it develops into a kind of compulsivity, where you feel like there's nothing you can do to fight it, you have to do it, it takes up all of your life, and you have patients tell you something like, there's nothing in my life but my eating disorder. Which, if we look at this graphic, is only, I think, partially true. It is true that the eating disorder comprises most of the attention that the person has, but also we have about a 5% green bar here still. And 5% of your personality is not a lot. It's still also, given how complex and nuanced and huge things personalities are, still quite a lot. I mean, ordering a coffee at the bakery sure only takes maybe 5%. So I think we have to remember that even though people are severely limited and burdened by their eating disorders, there's still a very considerable part of them there, and also that part is again suffering very much. So unless your orange bar actually reaches 100% and your patient dies, you are now the therapists and you have a patient in front of you with a severe eating disorder and you need to get them to move out of it. So how do you do that? I think first of all, it's important to remember that you're interacting with two different parts and levels of that person's personality. There's a small, infringed, suffering self as part, and then there's a huge part that's primarily occupied with the eating disorder. To combat that, I think clear and very strict CBT routines and discipline is the best way to get a handle on that. But on top of that, it's of course, we want the green bar, the self, and the frigid, frightened, suffering part to grow and push back on the orange bar. I think it's important that a lot of the motivation, or as much as possible, comes from the self within, so that it is the person themselves that pushes against the eating disorder part, because if we go back to the slide with the compensation, there's always something, some insecurity, some sense of overwhelmment, a whole lot of pain and feeling not in control that's compensated by the eating disorder. And if you push it back, by definition, it's going to come back up. And you're going to have to be ready and willing to accept it and let it sink in and work with it, which is a lot of the times going to feel worse than if you stayed in your eating disorder behaviors. So by definition, it's harder to go into treatment than to stay in the eating disorder. And I think you need to be ready to kind of stomach that to some extent. Otherwise, you run the risk of like physically recovering, but not having done the emotional work of working through the recovery. And then you'll likely have a patient that's going to come out of treatment and all of a sudden be confronted with a lack of self, or like knowing how to handle oneself. And it's, in my opinion, very likely that that patient will relapse very quickly. So the therapist, as a reminder, needs to engage with both, and also needs to know at which stage in treatment how each of those needs to be addressed and handled. Inpatient treatment programs, I think, can help a lot by putting a lot of the eating disorders worst compulsion on hold and kind of like anesthetizing them in a way. So now if you look at the relationship between the orange bar and the green bar is actually bigger than the orange bar. So it could be, like, it has more strength relative to it. And actually that gives the patient the power to make the choice maybe by oneself, or like step by step, you're going to be stronger than this part of your eating disorder. And although in the whole context it's still a very tiny step and the self is still relatively small, it is also, it's very important to learn that you are able to make these healthy and powerful choices for yourself, because it's also, I guess, a habituation of learning this way of making choices, and it's important to learn it the right way from the start. So I think also as you progress in treatment and as the self grows, it's important for the therapist to pass the responsibility of identifying which part of your self, the eating disorder, or you need to address at a certain point or in a specific issue, to pass the responsibility to figure out where to focus your attention to the patient, so that ideally the patient knows how to handle both sides of both his personality and his eating disorder, and to to come up with answers to handle them in a healthy way independently, because you want to be able to discharge the patient. And with the recovery process in full, always a lot of the times taking more likely years than just months, the patient needs to be able to identify those by himself and also make the appropriate choices by himself. Also, I think really important in this graphic are the fellow patients that you go through treatment with, because while eating disorders are very isolating experiences and you feel very alone in your pain and unseen, the very frightened or attacked self that we had still finds a lot of, companionship and understanding and compassion in other people in the same situation, and that can be incredibly empowering in my experience. So let's say we have somebody who's tough enough to fight themselves out all the way, push away the orange bar and get to 100% of the green bar, the self again. Well, we have to remember that person still lives and exists in an environment where there were some factors that were troubling them outside of them before they even developed the eating disorder. And while one was, gone and absent dealing with that, they haven't gone away, and there's still very much unresolved issues. So I think for the success to be lasting and for the patient to actually have all the tools that they need to not need eating disordered behavior for compensation in the future again, it is also necessary in a second step of therapy or second phase to work through all of them and find different strategies how to handle them, which is almost, in my experience, like a whole second therapy process. So once you have established them, I guess that's pretty much all you can do in terms of setting somebody up to not become eating disordered again. So when you're asking which approach do I use in therapy, I think the answer is going to be all of them. Like, you have your patient and you want him to be actionable and self-reliant and have a host of different strategies to handle the problems as they come. I think it's very good to have CBT just to have the direction of what healthy behavior means, and you need to have some structure and discipline. Also, analytical approaches are very important to understanding why you might feel insecure or pain or overwhelmed, and to have strategies to let that be and work through it, because that is also very challenging in a very different way. Also, I think approaches like DBT or ACT can be very helpful for fostering motivation and self-reliance. And then next to all of that, we also have strategies like music or art or dance that are where you express yourself in a very emotional way. And I think these might also be strategies to just strengthen the green bar, so to speak. It's important to remember, I think, that these strategies are going to look different for every person. People have different personalities, they live different lives, they like different things. But it's important to I think everybody needs their own personalized mix here. And to get a good sense of the mix that is actually necessary, I think therapy has to be seen more as a partnership between a patient that actually speaks up for all that's going on with him, and also a therapist who's looking at it from the outside and who's proposing strategies that are a good, healthy way to handle that. I don't think the therapist should be very strict in saying, oh, you just need to do this one thing. It's more like judging objectively, oh, is this a strategy we can roll with, or is it something where you might run into problems at a later point? So, up to this point, my presentation has been very theoretical, And as I mentioned at the start, I'm also a patient representative and I conducted a survey. So let's see whether this theory transfers into the practical field, at least in some way. So to set up the survey, I visited 3 outpatient groups in Berlin and asked them just to tell me about things that came to mind when I asked them how they experienced therapy. I wanted my questions to meet people where they're at and also to cover the most prescient issues that they experience. So with these experiences, 10 to 10 issues, approximately broad, openly phrased, qualitative questions were developed. Something like, what was your first point of contact for your treatment and how was the experience? Or was your outpatient therapy specialized for eating disorders? Because in Germany it's oftentimes not. And well, how was the experience again? Did you feel seen as a person with and next to your eating disorder in treatment? So, and the word count for all of these questions was unlimited. It was distributed to friends, to outpatient treatment centers, one inpatient facility also shared it, and through social media as well a bit. So there's a very broad people participating. And unfortunately, due to time constraints, I can't present you all of the answers today. So I chose the question to present what was especially motivating in your therapy. So first of all, I think we had 50 participants all in all, and the question was answered by 44 of them, which compared to other questions where you only had a lot of the times more like 35, because people could leave out the questions if they prefer to. That is a pretty high count. And then the answers were categorized, and yeah, there were different categories that were named. So when asked what was especially motivating for having success in therapy, 19 out of 50 people named things that were associated with their social environment. 8 people named their family specifically, although you have to know that half of them also mentioned a sense of duty, that the family cares for them or like so much that they feel like they have to be successful in treatment. It was different with friends, which 9 out of 50 people named. It was more just naming the friends. They were there, they were something to look forward to. People were really differentiated and nuanced when it came to describing the value of other patients. They were both motivating, a support, an inspiration. They also noted that you had to be mindful not to negatively affect each other. Just there was a lot of description and depth to these answers when they came to other patients. So that was pretty impressive. The next category were aspects related to the pathology of the eating disorder. 2 people said that it was very helpful for treatment that the therapist was competent and knowledgeable in eating disorders. 2 more said that it was very helpful to have the therapist confront them pretty directly of the potential dangers of your eating disorder. But then, in contrast to that, 37 out of 50 people named something related to individual aspects that was pretty helpful in treatment for them. For instance, we have 5 out of 50 people that said, oh, self-motivation was the most important thing for me. Like I had to want it for myself and that proved the difference. Others said, oh, I was starting to see myself, like accept myself in a more holistic way. I was being more realistic with having strengths and weaknesses. Also, I'm putting myself and my own needs first instead of always putting others first. Another thing that people mentioned was feeling seen, understood, and safe, both with friends, but also with fellow patients. Especially that people felt safe, I think really was a very moving thing to read. At the same time, or like equally, 4 out of 50 people named a very trusting relationship to a therapist as the biggest motivator. 10 out of 50 people said that individually starting to become fed up with being ruled and controlled by eating disorders and feeling the strain and the pain of it in their own life made them really fed up with it and that they wanted to get rid of it. And this was the topic that was named at the highest count in all of the survey, personal goals in real life are the single most motivating factor, it seems, in my survey for people to move out of their ED. And if we look back to the green and the orange bar, I think it's fair to say that this supports the necessity for the green bar to be strengthened as much as you can, because to me, I link all of these individual aspects to strengthening that green bar, and only 5 out of 50 people said that especially motivating was aspects related to the orange bar of their personality. So, to conclude this talk and foster more trust in therapeutic relationship, what would I, as a patient representative, like to see as improvements in how therapy is structured and organized? I think it would be important to introduce more organized, formal patient representation, both by types of disorder and comorbidities, but also in general. And it should be encouraged globally, especially in smaller countries. With these structures, you have a partner to collaborate with and do participatory research, and where you're trying to figure out what are principles that can be applicable to all, and where do the principles end, and where maybe do I need to start to look for individualization, as opposed to very strict CBT-oriented guidelines, which just don't cover all the individual aspects that are meshed into the disorder a lot of the time. I think, referring to that as well, next to the specialization for ED on the behavioral level, I think you need more nuance to the specific therapeutic relationship you need to have, or like be able to give when somebody has a very severe eating disorder. It's not as bad when somebody's already mostly out, but in this very specific place of extreme suffering, I think there are certain necessities that you need to pay more attention to. In all of this, I think it's important that patients and treatment providers remain in continuous communication. I don't necessarily think that they are always going to hold the same views. They are also representing different interests to a certain extent. So it's okay for there to be conflict and ambivalence between the two, as long as one can still see why the other side might have a good reason to express their views, or like to come to their views, and that vice versa too. Then I think we need more of a balance between more psychological and medical research, more into the psychology, also more qualitative studies as opposed to mainly quantitative ones, and also way more focus on applying the findings in practice, not just in theory. And I think in the second phase of treatment, once you have pushed the orange bar away, it could be very helpful to introduce more social work approaches into the treatment structure. And lastly, before I go, I think this was just me and my opinion. And equally, there should be a space for everybody else who has a lived experience in eating disorders to just give their feedback and try. I think we all want treatment to be more effective. And I think we can all, if we try to work together more, we could achieve a lot. So, thank you very much for your time. I hope you enjoyed the talk and found it interesting. And any patient representatives on here, I'm very happy for you to reach out.